everyone, and welcome to Wednesday Wellness, a free live educational series presented by Trinity Health Medical Group. Thank you very much for joining us this evening. Before we turn it over to our presenters, we would like to provide a few reminders. This presentation is being recorded, and you will receive a link to that recording over the next few days. If you have questions throughout the presentation, please use the Q&A chat bubbles, usually found near the bottom of your screen. During our question and answer portion, questions will be read aloud and then answered by our presenters. Without further ado, I would like to introduce Dr. Christopher Morgan, a sleep specialist and the medical director of our sleep program here at Trinity Health. Dr. Morgan, thank you so much for being here today.
All right, thank you. So I guess I will get started here. Thanks everyone for attending. It's always exciting to educate people about sleep medicine. And today we'll be focusing on obstructive sleep apnea and different kind of newer approaches to treatment in care, as well as some updates on some of the treatments you might have all know or heard of in the past. And for those that haven't heard much about sleep apnea, I hope that you'll learn a lot today in different treatments. So just as a reminder, for the attendees, you guys can submit chat questions during the talk or after the talk, and I will answer those questions towards the end of the talk. So just, if you need to, submit questions to the Q&A throughout. So I like to kind of start out with, because a lot of people have heard of sleep apnea and kind of what it is, that it has to do with breathing and disruptions in sleep. But a lot of people don't actually know what it looks like. And if they do, it's usually if they have it themselves, sometimes they don't see what the other person, I'm sorry about that. If they have it themselves, they don't really know how it looks when they're doing it. But you may be a spouse attending this and you may have seen it before. But this is kind of just a little video of what's like. So what happens is that the airway is being obstructed or blocked, and then the patient is trying to overcome that airway blockage by creating enough force and pressure to open the airway using the chest and stomach muscles. And then there's a big gasp for air. So what's happening in this video and with obstructive sleep apnea is we have the tongue and the palate that are relaxing during sleep and blocking the airflow. And when this happens, we can see that it really takes a toll on the body. And if that's happening throughout the nighttime, it can cause quite a few problems. So we also see that the oxygen levels drop when this happens. So the blockage happens, the oxygen goes down. It's a very common diagnosis. So we think over 25 million Americans have obstructive sleep apnea, maybe more. And a lot of people are undiagnosed. There are a variety of reasons for that. One, they may not know they have it, or some people just don't want to find out that they have it. They might think they have it. And we think about 25% of adults between 30 and 70 have sleep apnea. So it's pretty high prevalence. Some estimates even higher than that. And at least 10% have moderate to severe sleep apnea. 4 to 17% have sleep apnea with daytime sleepiness, which is an additional risk factor for things like cardiovascular disease, which I'll talk about on my next slide. So with sleep apnea, we have lots of different risks that are associated with it. Obviously, the poor sleep that happens from sleep apnea because of these breathing issues and the frequent awakenings during the night can lead to things like mood disturbances, depression, anxiety, loss of motivation, daytime sleepiness. which can lead to increased things like car accidents and impaired memory and concentration, obesity, diabetes, and then cardiovascular disease is a big risk factor. So higher risk of stroke, heart attack, high blood pressure. So we have all these kind of risk factors if you have sleep apnea that's not treated, that we really need to try to take care of for your overall health. Although most people with sleep apnea have some symptoms of sleep disruption or fatigue that bothers them. And with this, daytime sleepiness can come decreased work productivity. So not able to attend work because you're too tired or you sleep in. Family and social activities can be missed. Quality of life can really affect learning and memory, increased risk of substance abuse, risk-taking behavior, reduced decision-making, and difficulty coping with high-stress situations, being very inattentive and distracted. So a lot of adults that are diagnosed with ADHD actually have sleep apnea that is a contributing factor to that, or have sleep disturbances. And this is just a video of one of those consequences that can happen, which is issue driving, feeling sleepy when you drive. So this is kind of a dash cam that observed the driver. And you can see his eyes are closing slightly here. So you can see that it just takes a very split second of being tired or sleepy to have a car accident to happen. And most people don't realize that it's happening at the time. So it's very important that if we have sleep disruption, that we're paying attention to this when we're driving. So when we treat sleep apnea, there are some things that we know very well, like it lowers blood pressure. It may decrease the risk of heart arrhythmias and risk of complications after surgery, such as low oxygen levels. It may improve heart function and heart failure, and it may reduce mortality from cardiovascular issues such as heart attack and stroke. So we have seen some of these benefits. To diagnose sleep apnea, we have to do a sleep study. So some of you in the audience may have had a sleep study before. The most common sleep study that there is called a home sleep apnea test. So this measures sleep apnea looks at your breathing and your oxygen. Sometimes it may underestimate the total amount of sleep apnea because it's not looking at your sleep or your arousals from sleep, which is an important part of sleep apnea for many patients. There's also sleep studies in the sleep lab where we monitor your sleep as well as all the respiratory parameters. So we look at your breathing, your oxygen, and your sleep, and we can see these EEG or these brain waves to see how well you're sleeping and how often you wake up from sleep, which helps improve the accuracy of diagnosis and the severity assessment. Unfortunately, insurance companies have pretty strongly regulated when you can have these studies. So a lot of times we have to start with a home study before considering this in the future. So to treat sleep apnea, we have to do something to open that airway that's getting blocked. So the most common treatment and our gold standard is CPAP therapy. So you can see by these diagrams here, what CPAP does, it uses air pressure to open the back of the throat so that it does not get collapsed during sleep. And the mainstay is a CPAP machine. So these PAP machines have really gotten much better throughout the years. And they are much better at being very quiet, being more comfortable, easy to use. So they've done a lot of things to really improve the use of PAP throughout the years. There's a lot of different types of machines. We can have CPAPs, which have a single pressure, and BiPAP machines, and more advanced type BiPAP machines, which give you differing pressures when you breathe in and out to help regulate breathing or give you more a bigger breath. So the CPAP masks have come a long way as well. There's a lot of different brands out there. They're typically much smaller with improved line of sight for patients. There's masks that have the hose above the head so it doesn't disrupt you in front. Masks with minimal to no straps, and memory foam models, which make it more comfortable against the skin for those that have ever experienced skin irritation with with CPAP masks in the past. Despite us improving the technology, CPAP nationally has low adherence due to issues with like mask fit, pressure issues, skin irritation, convenience, nasal congestion, or just aesthetics in general. Claustrophobia can also be an issue. However, studies have shown that good education and follow-up with an accredited sleep center almost always improves compliance. Generally, compliance in well-trained sleep centers is 70 to 80% with CPAP. So just because nationally it's a lot lower, we can get better outcomes with CPAP if we go to a sleep center. Some studies have shown switching from a CPAP machine to a BiPAP machine may resolve 50% of the intolerance to CPAP. And there are some new devices out there that may help with CPAP tolerance. This is a new device called the VCOM, which helps to make it more comfortable to breathe with the air if that's been an issue with using PAP therapy in the past. So we have new things out there. We have better education and follow-up that really, for the motivated patient, we can get this to work for the vast majority of patients. But before people usually come to a sleep center, they're trying stuff at home, right? We're trying different things we see on the TV, on the internet. I know because I'm a sleep doctor, I get ads for this stuff all the time because I'm always Googling things about sleep and sleep apnea. And so I get a gazillion ads. So these are some of the things that I get on my social media feeds or my inboxes just because I've looked at things before. And a lot of these devices are targeted towards snoring, which are not sleep apnea. So that's different. Just because you're snoring doesn't mean you have sleep apnea. And although it can be a risk factor, right? But theoretically, these devices can improve sleep apnea because what they're doing is they're trying to pull the jaw forward in some way to open up the airway. There's also ones that are targeted towards nasal obstruction. So there's these, nose cones or breathe right strips that help with nasal obstruction, but don't typically help the root cause of sleep apnea, which is in the posterior airway in the back of the throat, relating to the tongue and the palate. So they may help. Typically, these devices don't last very long, especially the mouth guards, and they may not be durable. And again, not approved to treat sleep apnea. They've even gone so far as advertising the instrument, the didgeridoo, which is, you may have heard this, like an Australian, very low tone instrument to treat sleep apnea. Now, there is studies that have shown people that play wind instruments have a lower percentage of sleep apnea because of strengthening of the upper airways. So there's some research for having this advertisement. However, it's never actually been tested and shown with, certainty that it does that. So probably our most commonly used alternative is something called an oral appliance, or an oromandibular advancement device is kind of the full name for it. But in oral appliance therapy, what happens is you have the jaw that is moved forward by a dental device attached to both the upper and the lower jaw. You need to have good dentition, generally good dentition for this. If you have a lot of active dental issues, this is not a good option. And sleep apnea usually works better for sleep apnea that's more mild to moderate and worse on the back. However, people that have had moderate to severe sleep apnea can have good effect from this as well. And some insurances require this to be tried before moving on to further surgical therapies. There are multiple board certified dentists in Michigan and around the country, which you can look up at the American Academy of Dental Sleep Medicine website very easily if this is an option you would like to check out. A lot of different appliances are out there and available. So they even have ones that are, 3D printed appliances, ones that are effective for people that breathe through their mouth. And they have ones that connect to CPAP. So you can actually use a CPAP with the oral appliance, which can help reduce the total pressure of CPAP. This is a very common company used nowadays called ProSomnus, which they have different types of appliances as well with that. So there's a lot of different ones out there that can work, and we can use these in combination with other treatments. The other common thing we see is something called positional therapy, which basically in the past, sleep doctors would tell patients just sleep on your side because your sleep apnea is worse on your back. However, we found over the years that the compliance with this recommendation was very, very low, and patients typically didn't follow through with it continuously. There are some better devices out there that can do this now. So this is an example of we call a positional trainer, so they can actually kind of train you to stay off your back and stay on your side. So you can have just a short video of how one of these work here.
My back. That is why we invented the night shift.
The night shift is worn on the back of the neck. When you begin sleeping on your back, a gentle vibration begins. The vibration slowly increases in intensity until you change position. In addition to providing position therapy, the night shift monitors your sleep and sleep quality. The night shift report portal allows users to track their consistency of use, treatment effectiveness, sleep efficiency, frequency of interrupted sleep, and amount of loud snoring.
We designed Night Shift as a therapy that empowers the user to track their success.
It's a real small band. It's got two magnets put together. Fits right here, lightweight, you'll never even know you have it. Your body gets trained. When it vibrates, I knew automatically just turn over. She was not awake, we were not irritable in the morning, bickering at each other because neither one of us got any sleep. I wore it every single day so that everything we did was better.
What I disliked about the CPAP.
So, with these positional devices, it can help to train you to stay off your back. And that device particularly is starting to get approved by Medicare now, so it may have some insurance backing in the future. There's also these nasal EPAP therapies, which are basically devices that go in the nose and resist your breathing as you breathe out, basically creating the same kind of effect CPAP has, but at a lower level. They're approved for mild sleep apnea, and there's typically no machine or tubing associated with it. And these can be effective for mild sleep apnea, although long-term use is still unclear how consistent people will be throughout their life using one of these. There are other new treatments, such as this device called Excite-OSA, which helps to strengthen the upper airway muscles by providing neuromuscular stimulation to the muscles in the airway, used for 20 minutes a day. I just have a short video on how
With the aim of improving endurance of the upper airway dilatory muscles, Excite-OSA provides a novel daytime therapy for patients with mild OSA and primary snoring. The compact device applies low-frequency neuromuscular electrical stimulation, NMES, via 4 electrodes that rest directly on the tongue, stimulating the upper airway muscles. Simple and comfortable to use, the daytime therapy requires only 20 minutes of NMES each day to increase responsiveness and prevent excessive relaxation of the tongue muscles during sleep. According to clinical research in skeletal muscle stimulation, NMES has been shown to result in a change in myofibrillar protein expression to induce a phenotype shift from fatigue-prone to fatigue-resistant fibers with the strengthening of the cytoskeleton. In summary, Excite-OSA's innovative, clinically proven daytime therapy trains the tongue and upper airway muscles to be more resilient.
So you can see that one kind of works. It's a very different way of working, but it can be effective in mild sleep apnea. The downside to this is probably cost. There's no insurance approval for this type of therapy, but can be options for milder sleep apnea. There's also a device called the INAP, which is a type of called negative pressure therapy. Basically, it helps the tongue to be displaced from the back of the throat, and it's much smaller and pretty easy to use. It's a short video.
INAP creates a gentle vacuum in the oral cavity, stabilizes the tongue and soft tissues, and frees the airways, thus enabling uninterrupted sleep. Operation without mask, portable and rechargeable, excellent wearing comfort, discreet and quiet operation.
So you can kind of see how that one works too, that it just pulls that tongue away from the back of the throat. So again, these options can definitely, these options can be good for, and that device actually works for moderate to severe sleep apnea as well. So again, we haven't had insurance approval for that device yet. So cost is usually the main factor keeping people from trying that. Surgical treatments. So if these other options fail, surgery can be done. And the most common treatments for surgery include tonsils and adenoids removal, while this is done mainly in children, or palatal expansion, again, in children. Or you can remove or manipulate the palate and the uvula to try to get those away from the back of the throat in combination with other surgeries like the tongue reduction or tongue advancement or nasal surgery. And in previous studies with these, even combination surgery is only about 50 to 60% successful, and it typically does not resolve the OSA in most patients. So these are some examples of those surgeries. So basically removing the palatal tissue or reorganizing the palatal tissue so that it comes further from the back of the throat, or trying to advance the tongue towards the back of the throat, or in a couple different ways here. There's another surgery called maxillomandibular advancement, which works well for even severe OSA and has a good success rate. However, it's the limiting factor in this is it's a longer surgery, or it's a more invasive surgery with longer recovery time, but is very effective and can be done for treatment of sleep apnea. Hypoglossal nerve stimulation is a newer type of surgery for sleep apnea, where this is an implant that goes under the skin and has a lead that goes up to the tongue or the nerve that supplies the tongue to provide gentle stimulation to push the tongue forward and open the airway. It's performed by an ENT surgeon, and it's followed up by a sleep center. It's a small device that goes under the skin, like I mentioned. To qualify for this device, you need to have more than 15 breathing pauses per hour, which puts you in the moderate to severe category of sleep apnea. And you must not have significant central sleep apnea with this device. You have to have tried CPAP and either not gotten benefit from CPAP or not able to use CPAP therapy. And ideally, the best candidates that are going to respond to this therapy are people with BMI less than 32, although Medicare does approve for BMI less than 35 and potentially could be higher BMIs in the future. The problem is the higher the BMI you go, the less response rate that you have to the therapy. Typically a safe outpatient surgery. There's 2 small incisions in the chest and the neck where the surgeon has to place the electrodes, and has a pretty quick recovery overall with extremely low complication rates. So this is kind of a video explaining a little bit more what it is.
Inspire is a treatment option for some sleep apnea patients who cannot use or get consistent benefit from CPAP. It's a small device implanted during an outpatient procedure, and it's all under the control of the patient with the Inspire Sleep Remote. Patients simply turn it on when they go to bed and off when they wake up. Now, let's take a look at how Inspire treats the root causes of sleep apnea. During sleep, the muscles and soft tissues of the throat can relax, block the airway, and cause apnea events. Inspire treats sleep apnea by working inside the body with the patient's natural breathing process. The system is placed under the skin of the neck and chest during an outpatient surgical procedure. The device is turned on by the patient with the sleep remote seen here. After the patient falls asleep, the system syncs with breathing patterns and then delivers mild stimulation to key airway muscles throughout the night to keep the breathing passages open. The back of the airway is now clear, and the patient can breathe during sleep.
I keep the remote control right next to my bed. I simply just reach over and turn it on every night and go off to sleep 30 minutes later, and I don't wake up when it starts and activates. And very easy to use. It's like a push a button and go to sleep.
So you can kind of see a little bit more how it works and how patients react to it. Inspire therapy was improved in 2014 and is used by over 50,000 patients worldwide. Has had exponential growth in the last couple of years. It's more every day that are being implanted. What happens with the device, this is actually one of my patients that I took a video of his tongue, but you can see that when it's stimulated, I'll show it here. The device is stimulated, the tongue moves forward like this. So we have the back of the tongue comes up and forward to remove it off the back of the airway. I'll show it again just so you can see. Generally, it has good patient satisfaction. Vast majority of patients are happy they got the device and feel that it helps them feel better. It's not as effective as CPAP, but generally a very good outcome for surgical options that we have. So this was some of the original published data from the STAR trial back in 2013, which showed almost an 80% decrease in respiratory events with the device. About 40% of patients were cured. So in other words, their sleep apnea was less than 5 times per hour. And majority, about 3/4 of patients were brought down to at least the mild sleep apnea range. In our clinic, our results have shown about a 70% decrease in respiratory events. So the breathing, 70% decrease in breathing pauses overall with the device. Our patients started a baseline of 36 times per hour and it decreased to an average of 10 times per hour. The other thing we see with the device is a decrease in daytime sleepiness. So in the original studies, they had that were very sleepy with a sleepiness scale of 12, which we define this scale, anything above 10 is excessively sleepy. And that's decreased to 7 and 6 as time goes on with the device. We've also seen a decrease in these scales as well with our patients. Despite this, there are still patients that can't tolerate this device due to a variety of reasons with tolerating the stimulation. And it's the nice thing though is we can adjust it. So if people are not having or people are having trouble, we can adjust it to different settings. And most of the time we can find one that's comfortable for patients and have some treatment effect. And we have a lot of steps to go through if there's patients that are struggling. But I would say, over half the patients find benefit from it pretty quickly after starting it. This is just kind of a measurement of patient satisfaction. 95% would choose Inspire again when they filled out satisfaction surveys. And generally compliance is very high. So, in our clinic, patients average greater than 6 hours of use every single night, which if you compare that to CPAP use, which national averages are around 3 to 4 hours, this is definitely a much higher usage of the device, which treats your sleep apnea longer through the night and theoretically should provide benefits long-term for patients as well. There's still a lot of studies going on currently with the Inspire device and if it can help change cardiovascular outcomes and other things like we've had with CPAP. In our clinic, we use kind of a general pathway of how we treat sleep apnea. Our first treatment is always CPAP, and our second treatment is typically CPAP, but dental devices can be thrown in there depending on the right patient for first-line treatments. And then our second and third-line treatments may include things like hypoglossal nerve stimulation or other different types of surgeries that can be done, and some of the other devices that I showed you tonight too. So how this process typically works, if you were thinking about the Inspire device, is you would be screened over the phone and be scheduled for a consultation. We review your prior sleep studies or order a sleep study. And if you've had a sleep study that qualifies and you've tried CPAP and not done well with it, then we would refer you to an ENT physician to help finish that evaluation. Sleep studies typically have to be done within the last 2 years, and you have to have failed CPAP therapy in the past. The ENT office will then do something called a DICE procedure, which stands for drug-induced sleep endoscopies. Basically, they use a camera to look down your throat when you're under some sedation. And they see how the throat collapses when that's happening. And if you're a good candidate, which about 90% of people are after that procedure, then you would be scheduled for the implant surgery. And about 6 to 8 weeks later, you would come back to our sleep office for us to actually activate the device and get you started on treatment. This is covered by almost all insurances now. And there are different insurances have different qualification criteria, but generally we can get people approved that are, we think are good candidates for the procedure. This is an example of what the DICE procedure looks like. So again, they're looking with the camera at the back structures in the throat to see how the throat basically collapses when you're sedated or when you're simulating sleep. Then at the sleep clinic, we turn on the therapy about 6 to 8 weeks after the surgery. We establish what settings would be good to start with. And then at home, the patient can actually titrate up the device by using the remote control. And so this is patient guided by your comfort. So the first goal is getting patients comfortable. And then we typically do a sleep study, anywhere from 6 to 12 months after starting the therapy. I mean, 3 to 12 months after starting therapy, depending on how your adjustment's going and how you're doing with the device. The remote also links to an app that can show you your data and usage every single night. And that we can actually access that app from a cloud portal. So kind of like if anyone's had a CPAP, the CPAPs go to a cloud portal where the doctors can look at it. Same thing with the Inspire, that can go to a cloud portal where we can look at your usage as well. The disadvantages is you have to come in to the clinic for us to change the settings. We currently don't have a way to change the settings of the device like we do with CPAP from home. You have to come into the clinic anytime we need to change or make an adjustment to the device. That may be coming in the future, I'm told by the company, but as of right now, patients always have to come in. Long-term follow-up considerations with hypoglossal nerve stimulation. It can be combined with other therapies, such as positional therapy. We do this pretty commonly in patients that we want to get better control, or oral appliance devices. It's now MRI compatible with the device, and it also works fine with any CAT scans as well. But 1.5 Tesla MRIs can be scanned any place in the body with the device. The battery lasts about 11 years on average. So you will need another procedure to replace the battery, but it's a simple procedure. And the device is removable, although it's rarely done. I think in our practice, we have 120 patients, about 120 patients now, and we've only had 2 patients remove the device for different reasons. So it's not very common. So our sleep center does accept, new consultations for patients interested in any of these therapies I've talked about today. So this is just our contact info, and I'm sure the organizers can get you that as well. So plenty of time for questions. I figured there's usually a lot of questions with this presentation, so I will stop here and try to address questions for everyone.
Yes, thank you so much, Dr. Morgan. We are going to transition to question and answers. So as a reminder, Dr. Morgan so nicely put up on the screen kind of a diagram of where you could find that Q&A chat. It's down near the bottom in your toolbar. Dr. Morgan, we did get a couple of questions emailed over to us, so I am going to start with those if you don't mind. I think you may have briefly touched on a couple of them, but if you could just kind of cover them anyway, I would really appreciate it. The first question is, I find that I'm waking up in the night, but I'm not convinced it's sleep apnea. How do I know?
Yeah, so I think that's one of the reasons that sleep apnea is underdiagnosed in our country, right? Is because people feel that they're waking up, but they don't notice that they're snoring or stopping breathing. But it's very hard for yourself to actually notice that when it's happening. You really need a sleep study to determine if sleep apnea is causing you to wake up. And there can be a lot of things that cause you to wake up at night, right? You can have joint pains, you can have mood problems, anxiety, kids waking you up, pets waking you up, can be too hot or too cold. So there's so many different reasons that can wake you up at night. But sleep apnea is one of the very common reasons. So if you don't have a clear reason as to why you're waking up, or even maybe you think you have a clear reason, but you're not 100% sure that's the only cause, then I'd recommend talking to your doctor to look at a sleep study, which can tell us if your breathing is part of what is causing you to wake up at night.
Thank you. The next question that we received via email was, what do you think is the biggest risk factor for sleep apnea?
The biggest risk factor for sleep apnea. Well, there are a lot of risk factors for sleep apnea. Probably the one that has actually the highest association with sleep apnea is hypertension or high blood pressure. People that have poorly controlled high blood pressure on 3 or more medications actually have a 90% risk of sleep apnea. But other things, such as you ever had a heart attack, if you ever had a stroke, those have 70% risk of sleep apnea at least. People that have obesity, that can be a much higher risk for sleep apnea. And then other medical problems like heart arrhythmias, so either too fast or too slow beats of the heart or atrial fibrillation, those also have very high associations with sleep apnea and are a risk factor. And then just, I think patients that are actually observed to be stop breathing, that associated with a very high risk. And there's actually a scale that calculates this risk called the stop bang scale. You can look it up on the internet, but you can do one of those on yourself if you want. And basically it's very easy to do. It's just, do you have loud snoring? Do you stop breathing? Has somebody seen you stop breathing? Do you have high blood pressure? What neck collar size do you wear? How far around is your neck? And then do you have other risk factors like high blood pressure? And it kind of calculates that risk. Generally, if you have 3 or more of these risk factors, you have a moderate to higher risk of having sleep apnea.
Thank you so much. The next one that we did receive was, could you provide some detail about what to expect from a sleep study?
Yeah, so it depends on the sleep study. So there are a lot of different types of sleep studies out there. The one we use is a pretty simple device, with the one we use for home testing, I should say, where you have a little nasal cannula and a device on the chest, and then a monitor on the finger that measures your oxygen levels. And we associate the breathing with the oxygen to see if there's sleep apnea going on. There are a lot of other devices out there, though. There are some sleep tests that you just wear a finger monitor, and it can tell if you have sleep apnea just from that. There are some monitors that you wear kind of a headband device out there. And then for an in-lab sleep study, so one where you actually come into our sleep center, you sleep in our beds here, there's a sleep technician that hooks you up to all the monitors. Those, have a little more expectations. So the home ones, basically, you just have to pick it up, put it on yourself, and bring it back. The ones for in the sleep lab, there's a little more that goes into that. We have patients bring their own medications in, whatever they normally take. We want them to wear loose clothing so the technicians can hook up all the leads and monitors. Most patients come in around 8, 9 o'clock at night, and the technicians, have about an hour getting you set up, and then people go to bed around 10 or 11 and are woken up around usually 6 to 7 o'clock in the morning, usually 6 o'clock in the morning most of the time. With our technician schedules, but we can accommodate anybody's schedule. So if you're a third shift worker or a late night worker, we can accommodate those schedules with our sleep technician staffing. So it just has a little thing. You can also have family members come in if you need support. So if you need a caregiver, if you're a parent of a child who's having a sleep study, that's typically available at most sleep centers as well. The thing people complain about the most is usually the goop in their hair. So that's something that you have to kind of clean off when you get home pretty well. And, it's not going to be the most comfortable sleep of your entire life. If you're really worried about being able to sleep, talk to your sleep physician. And a lot of times they can prescribe you a medicine to bring in to help if you're really struggling.
Thank you very much. All right, our next question is, what is central sleep apnea?
Yeah, good question. So, so this talk was all about obstructive sleep apnea. Central sleep apnea is when you stop breathing, but the airway is not obstructed. So the airway is open. So you're still able to breathe, but your brain stops you from breathing despite your airway being open. And this can be caused from a variety of things. So, the common things that are caused central sleep apnea can include cardiovascular problems. So, things like heart failure or atrial fibrillation can have a higher risk. Also, patients that are on opioids have a higher risk of central sleep apnea. Patients in high altitudes, not too much of an issue here in Grand Rapids, but that can be a risk factor. So there are certain medications and medical conditions that can cause that, but some people just have a natural tendency to have more central sleep apnea. So they normally our brains will keep us breathing during the night no matter what happens, no matter if we're waking up or going to sleep or changing positions. But some people's brains are a little more sensitive to that. So when they're falling asleep or if they have an arousal or wake up, they may stop breathing as the brain is trying to adjust their breathing parameters in the blood, like the CO2 levels and things, so that they can regulate that a little bit better. And the way the brain does that for some people is by having you stop breathing to help regulate those levels in the blood. And some people just have more sensitive systems and tend to have central sleep apnea. But it's treated very differently from obstructive sleep apnea. We can still use machines like the PAP therapies. Specialized machines are usually the most mainstay of treatment for central sleep apnea, but there can also be other things such as oxygen therapy, or there's even a new device. It's an implantable device similar to Inspire, but it's a little less invasive. They can stimulate the diaphragm to help you breathe. So that's called the Remedy device, and that's also a treatment option for central sleep apnea. That's kind of a very short spiel. I could do a whole nother 15 minutes on central sleep apnea. So,
All right, well, thank you very much. Our next question is about Inspire. How long is the Inspire surgery?
oh, it's pretty quick, about an hour. So it's not very long. So yeah, and it's the surgeons in Grand Rapids that do it are very well trained. They're very quick. They get it done pretty quickly. So yeah, but it's outpatient. Recovery is pretty easy. So
Thank you. Also about Inspire, does the Inspire device require special screening when you fly?
no, it's just like a pacemaker. So you just tell the TSA or the security that basically we just tell patients say I have a pacemaker because that's what it is. It's a pacemaker for your tongue is what it is. So, but they're very accustomed to medical devices and there's no special screening that has to be done as long as you tell them.
Thank you. The next question, and hopefully you'll be able to understand what I'm saying, because it's more medical. If your hemoglobin rises, how low is your oxygen level to cause this?
Yeah, I don't understand that question. I'm not quite sure what that means. If your hemoglobin rises, well, usually, so I'm trying to figure out what they meant by that question. I guess did they write it in the chat?
It's in the chat. So if the individual that submitted that, if they would like to provide a little bit of clarification, we can come back to that one.
Yeah.
Okay.
Yeah,
Well,
I mean,
then
because the oxygen goes low when you have sleep apnea, and that causes the apnea to happen to try to your brain tries to get itself to breathe again, but it usually doesn't have any direct effect on hemoglobin. Hemoglobin is usually a measure of the amount of blood cells that you have there. So that can, if you have low hemoglobin, that can so that's kind of a different question. I don't think, and there's not like a direct answer for it. So.
Okay, yeah, if the individual that submitted that, if that did not cover your question appropriately, please provide some additional context and we'd be happy to come back. All right, so I'm gonna move on to the next one. And it is a little bit specific. I've never had a sleep test, but probably have mild OSA. I've tried many anti-snore devices over the years, but the only one I have found to work for me is a tongue retaining device. It's a $10 device that uses suction to hold my tongue forward to prevent it from blocking my airway. I've used it effectively for many years, but the only drawback is sometimes it falls off while sleeping. Is there another variation of a tongue retaining device that might work that won't fall off while sleeping?
This is a great question, and this is actually one of the, well, I actually didn't have this in my presentation, but tongue retaining devices are another option for an oral device that can treat sleep apnea. The patients I've tried that on in the past have been not comfortable with it. So I don't recommend it a lot. I think it's hard to sleep with for many people, but you know, they can be used, and they basically, like you said, holds the tongue out away from the throat, and you kind of stick your tongue in it and it suctions your tongue and pulls it out. Yeah, and sometimes it falls out. That makes sense. I don't know of any other versions of that specific device. However, the one device I mentioned, the INAP, kind of does the same thing. It sucks your tongue forward. So if you're used to that sensation of your tongue being suctioned forward, that may be a good alternative for you. And the nice thing about that device is you can return it. They have like a money back guarantee if it's not working. And you can still test if the sleep apnea is being treated with that device. And if you haven't tested that with the tongue retaining device, you may want to formally like get a sleep study with it to make sure that it's treating the sleep apnea. But I don't really know another way. They do make mouth tapes out there that help to hold the lips closed. So you could try things like that. The non, you know, the minimally, the adhesives that don't disrupt or that don't cause skin irritation as much. They make a lot of those out there where maybe you can try to tape it to your mouth a little bit so it doesn't fall out as much. I mean, that's just off the top of my head thinking there, but I don't, and the best alternative similar is that INAP device that I showed. So.
Perfect, thank you. Next one, my sleep study showed that I had an AHI.
See, AHI of 11.2.
Of 11.2, which is mild, but most of the data came from when I was on my back in the study, which is not my normal sleeping position, but because of the attachments, I could not sleep on my side very well. Could I get by with a dental device instead of a CPAP?
I would have to look at your specific sleep study to give you a better answer to that. But generally, if you have mild to moderate sleep apnea that's worse on your back, the answer would be yes, that an oral appliance may be an appropriate option if you have reasonable dentition.
Thank you. Next one is, what is the average oxygen level for elderly adults during the night or when sleeping?
That's a good question. I don't know the answer to that off the top of my head, although, you know, typically even in elderly adults, I think oxygen should be in the middle, you know, around the mid 90s throughout the nighttime. So, but if you have other underlying medical issues, that may not be normal for each person, right? So if you have a condition called COPD or emphysema, where you have actually breakdown and damage of your lung tissue, you won't be able to get up to the same oxygens as someone who doesn't have any lung damage. So those patients may rest around 88 to 90% during the night, and that may be normal for them. But person without any lung or heart disease that's just older, I would still expect their oxygen levels to be in the mid 90s during the nighttime. So.
Okay, thank you so much. I think that might have been our last question. So if there are no other questions for the evening, I think that we can go ahead and wrap up this wonderful presentation by Dr. Morgan. And thank you again for answering all of those questions that we received. We appreciate it. We would also like to thank everyone who joined us this evening, and we hope you will join us for our next Wednesday Wellness presentation. Thank you again.
Thank you, everybody.